All right, well, thank you everyone for for registering, and most importantly, for your interest in learning more. And tonight we are very pleased to provide a session on women and heart disease. It's really interesting. It's just such an emerging subspecialty within cardiology. So I think you'll all find something that's going to be of interest here. I just want to say, definitely we are going to open up for Q&A. Request is that we do it at the end, if that's okay. And for those who are watching us on Zoom, please type in your questions as they come up during the chat, because they will definitely be read, and Dr. Sopogu will definitely answer them for you. So I am very pleased to present and introduce you to Dr. Sopogu. She is originally from India, did some initial medical training there, and then when she came to the States, after finishing her residency, she decided that women and cardiovascular health was a real interest. And so she chose to go to Cedars-Sinai, where one of the world-renowned leaders in this specialty, is, and she did a 2-year fellowship with them, followed them by a 3-year fellowship through UCI Health, where she also spent some time at Long Beach Memorial Hospital. So we were very, very lucky that she chose to accept the offer to be on full-time staff afterwards. And I think that you are just going to really enjoy. There's a lot of great information. And as questions come up, write them down. Because we will definitely take all those at the end. So without further ado, Dr. Nissi Sopogu.
Good evening, everybody. Thank you so much for being here on a weekday evening, Wednesday, the hump day, and also it's pouring outside. I was driving from my clinic, and I'm like, oh, I don't know how many people will turn up. So I truly appreciate all of you guys, all of you gals, and some guys here that have, taken some time out of your schedule to be here to learn about women's heart health. So like Rose said, if anybody has any questions, let's take them after I'm done with the presentation, and let's see how I can answer best your questions. And all right, without further ado, all about women's heart health. Obviously, I can't give you all about it, but as much as I can to make it useful. All right, so the objectives for my talk today are going to be prevalence of heart disease and heart disease in women, specifically, differences in risk factors and symptoms in women for heart disease, appropriate testing and treatment. So I wanted to start off my talk just by showing you this slide. This is a very fresh off-the-press slide from American Heart Association. It was released, I think, 4 weeks ago. And this is a random, sorry, go back. How do I go back? Okay. So this is a survey that they did with the general population, and around 6,000 people. They asked them, "Oh, what do you think is the cause of death? What do you think is a leading cause of death?" And surprisingly, only 49% of the population thought that heart disease was the #1 killer. Some of them thought some of them weren't sure what was the reason for the #1 cause of death in men or women. Some of them thought it was cancer, then some of them thought it was diabetes or stroke or pneumonia or influenza. Well, that was right for COVID times, I guess. But it's surprising that only 49% of the population, and this is from 2024, knew that heart disease was the #1 killer. So here is another fresh off the press statistic that I wanted to lay before you before I plunge into my presentation. So on an average, someone in the United States dies of cardiovascular disease every 34 seconds. That's pretty profound. Like, somebody is dying of a cardiovascular disease every 34 seconds, and one female dies every 60 seconds because of a cardiovascular disease. And there's one person that dies every 3 minutes and 14 seconds because of a stroke. All right, so let's look at the prevalence of cardiovascular disease in the general population. And this is broken down nicely by ages between 20 to 39, 40 to 59, 60 to 79, and 80 plus. And blue columns represent men, red columns represent women. And this is a study from the National Health and Nutritional Examination Survey between 2013 to 2016. It was published in 2021. And they looked at cardiac diseases, including coronary artery disease, heart failure, and stroke. And you can see how until the age of like 40 to 50s, late 50s even, that women, the cardiovascular disease prevalence in women is much lesser compared to men. But after the age of menopause, when the transition happens, you see how women tend to be more predominantly affected by cardiovascular disease, and they take over. They're more in number than the men in the similar age group are. So this transition here is pretty significant. And we'll talk a little more about it as I go through my presentation about the significance of menopause as well in cardiovascular disease. Here is another chart just to understand the cardiovascular disease, the deaths because of cardiovascular disease all the way from 1980s to 2020. And it's a nice graph to show us. The blue line, again, depicts men, cardiovascular disease and deaths in men, and the red line depicts women. And I want you to notice here in 1990, when the death rate for women actually started to go up, right? And this is around 1990 is when National Institute of Health, NIH, had the first female President Bernadine Haley. And she looked at it and she's like, we're doing something wrong. Like, why are the numbers for women dying of heart disease so significantly high compared to men? Maybe we're not looking at women like we're supposed to. Maybe we have to, the Yentl syndrome, maybe women need to look like men for science to take an interest and to do more research in them, There was a lot of question around what's happening with women, what needs to be done differently, because until then, right where the curve is still going up, even before the 1995, the mid-mark where it starts to sort of stabilize, they were thinking that, women had heart disease because after menopause, there's lack of estrogen. So let's just give them estrogen, and that'll help decrease their heart disease. And let's just educate women to make better healthy food at home, because heart disease was thought to be a predominant killer among men. It wasn't truly recognized and studied in women, right? So then a lot of changes started happening when the Women's Health Initiative started in mid-90s, and then they started looking at women and other causes that could be prevented and made a huge impact even until today, where we see that the number of deaths because of heart disease has started to improve significantly. But you see now later in the 2015s and early 20s, again, women are starting to pick up for cardiovascular deaths. So it's pretty significant, the journey that we have taken in the evolution of how many people die because of cardiovascular disease in women. So there's a lot of work to do still that's pending. So let's look at this survey that was done among women. The first survey that I showed you was just general population, random people, 6,000 people that they asked. This is among women, They asked women what they thought, what disease was the leading cause of death. This was in 2009. 64% women said that, heart disease is the #1 killer. However, in 2019, only 43% of women thought that heart disease is the #1 killer. So instead of their knowledge and awareness improving, it went down, because many of them still thought that any kind of cancer or breast cancer was the leading cause of death. So why is there so much disconnect between what we are seeing in numbers with women dying of heart disease and women having a risk of cardiovascular disease burden, and so much effort from national outfits like the American Heart Association or the American College of Cardiology trying to educate this population and educate the physicians about it? Well, because, Until the early 90s, still, most of the cardiovascular studies were done on men. If we look at major studies, there were only very few percentage of women included in study. It wasn't until Bernadine Haley became the president and took the initiative to make it a mandatory reason for cardiovascular research to include women, and if they don't, then they have to give a reason as to why they're not able to include women, and those changes came into practice only in the last decade or so. So until then, we didn't have a lot of information, right? Because it's only like 10% women, 12% women. Anyways, this is to show how sorry, I keep doing that. This is a study to show how many studies were screened. This is from clinicaltrials.gov from 2010 to 2017 that identified 740 trials for analysis of women representation. This is all like cardiovascular trials that were registered in 740 trials, and overall representation of women was as low as 38%. And we're still as many as there are men on this earth, but we still didn't have enough representation. This is another study that looked at the participation of women of cardiovascular disease clinical trials again, and the prevalence and corrected estimate. So in order for us to be 50% in the study, we should be between 0.8 to 1.2% here on the y-axis. And you can see there's only very few studies that made it across to the 50%, like AFib, which is a very common condition in women. Pulmonary hypertension is very commonly studied, more in women actually. But you can see acute coronary syndrome, people dying of heart disease, coronary artery syndrome, again, blockage in blood vessels of the heart failure syndromes, hypertension. All of this was lacking in its representation. All right, now let's look at traditional and non-traditional risk factors in women and how they're affecting cardiovascular disease presentation in women itself, right? Because of research, and more research into women in the last decade or last 15 years at least, we have now a lot more information to tell us that, yes, we have traditional risk factors like hypertension, diabetes, being obese, smoking, but there's very specific risk factors that women have through our life cycle that contribute an additional risk factor to the traditional risk factor that we carry. And here, so I'm actually going to talk about each of the traditional risk factors and try to highlight how each one of that affects women differently. So if a man was to have hypertension versus a female patient to have hypertension, it doesn't have the same impact on their cardiovascular outcomes. It still has a different effect on the cardiovascular disease, both in men and women. So let's look at hypertension. So all these statistics that I have in this format are fresh off the press. They were released like last month by American Heart Association. And here, I just want us to understand how significant it is, right? So hypertension, 122.4 million, or 47% of US adults are estimated to have hypertension. So 1 in 4 adults in the United States reported achieving adequate leisure time aerobic and muscle strengthening activities to meet physical activity guidelines. You know, this is like when you recommend exercise for hypertension control before you start them on treatment, trying to inculcate some lifestyle changes. Not everybody is able to, you know, set apart that time to do it. So talking about hypertension itself, so higher prevalence of hypertension is seen in women, and especially over 60 years of age, more than in men. And however, even though hypertension is more prevalent in women, there is less control in women than in men. We don't meet goals. While men and women are effectively placed on antihypertensive treatment, women are less likely to attain targeted blood pressure reductions. Why is that so? Based on my practice and my training thus far, I can say that it is it is because most of the medications, when the trials came out over the decades, had a lot of men in their studies to look for side effects and what the effect of the medication is on their metabolism and whatnot. And women tend to have more significant side effect profile or a more complex side effect profile, or we could be more sensitive to changes in medications, or we could also be very hesitant to be on medications itself to begin with. So it is complicated managing women, but also we should aim, as physicians, we should aim for the guideline-directed goals, and as patients, women need to understand what the guideline goal is for them, because many of my patients, when they come back to see me for follow-ups, and I'm like, okay, so how was your blood pressure? Oh, it was good. I'm like, no, what were the numbers? Oh, it was within the normal range. What is the normal range? Oh, it's in the 130s, 140s. Well, that's not normal. That's elevated. So I always ask my patients to keep a log and bring it back to me so I know what exactly their numbers are. And it's very simple to take care of, initially when we do diagnose hypertension, then there's lifestyle modifications. And this DASH diet here, and you can Google the DASH diet. It's a very simple diet with low salt, good protein, good vegetable and fiber diet in it, and amount of fluid you need to take to help control the blood pressure, to maintain at a normotensive goal of less than 120/80. Exercise is another lifestyle modification. Like I said, hydration is another modification that we could use to control the blood pressure before we get on to starting on medical therapy to treat it. All right. Diabetes. Here, let's see. So diagnosed, 29.3 million adults have diagnosed diabetes. 29.3 million. That is pretty significant. And 115.9 million adults have pre-diabetes. That is when your A1C levels are between 5.7 and 6.4. So you're still not diabetic, but your sugar levels are wavering between moving over to greater than 6.4 and being a complete diabetic patient at that time. So let's see how diabetes affects women differently than it affects men. Women with diabetes have a threefold excess risk of fatal coronary artery disease compared with non-diabetic women. Earlier occurrence and higher mortality in diabetic women compared with diabetic men, and there's lower revascularization rates in diabetic women compared with diabetic men. Now, when women have a heart attack, they're saying that it occurs earlier, and also we have lower rates of revascularization, which means that when you have blocked arteries, that women don't get all of their blockages resolved. Because A, the blood vessels in women are smaller, and B, sometimes for men, the blockages, when they happen, they're more focal. They're at a specific spot. You can go do a stent and leave it. But with women, our atherosclerosis is also different in the way it forms, and it can be more diffuse and throughout the blood vessel at different spots, and not one spot needing one stent and fixing it. So there is, based on how our pathophysiology is, it also makes it difficult for them to intervene. Heart failure, diabetic women have higher risk of developing heart failure compared with diabetic men. And diabetes is a stronger risk factor for stroke in women compared with men. And it's a risk factor for development of claudication, where you have atherosclerosis or plaque buildup in the blood vessels of your lower extremities. So when you walk, you have pain, so you have to stop, and then you wait for a little bit, it gets better, and then you start walking, and then that's claudication. Usually most commonly seen in smokers that have atherosclerosis significantly in their lower limbs as well. So it is a stronger risk factor for development of claudication in women compared with men, and decreased long-term survival in women undergoing revascularization and increased post-surgical mortality are seen in diabetic women with peripheral arterial disease compared to diabetic men. So this is pretty significant, right? If you and your male partner have diabetes, your risk for having all these things are much higher and more common to see these complications in you compared to your male partner. All right, so let's look at hyperlipidemia, my favorite. So 25.5% of United States adults have high LDL, and here the cutoff given is greater than 130 milligrams per deciliter, and 3.72 million deaths globally were attributed to high LDL in 2021. That's pretty profound, pretty significant, right? But the cutoff here is pretty generous. They said LDL level of greater than 130 milligrams per deciliter for primary prevention for any person that doesn't have any risk factors or they're low to moderate risk for coronary artery disease. The goal LDL for you, for me, for anybody is less than 100. Okay, and if you have diabetes or any other conditions that add to your risk of coronary artery disease, then your LDL level should be less than 70. And if you're somebody that has coronary artery disease or plaque in the blood vessels already or had a stent, then LDL goal should be less than 70, even up to 50. For better outcomes. So among women with dyslipidemia, dyslipidemia has the highest PAR at 47.1% compared with all other known risk factors. So dyslipidemia contributes most significantly towards development of coronary artery disease compared to diabetes and hypertension and obesity and inactivity and smoking. And atheroma regression, so if we have plaque and LDL lowering may be even greater among women on statins than in men. So if a female patient does have plaque in her blood vessels and high cholesterol levels, then treating them with statins has a profound impact. It helps in regression of the plaque and decreasing the LDL levels pretty significantly. Our response to statins is much more profound than men can respond to statins. But unfortunately, not many women are actually placed on statins. And if there is a statin intolerance, then there's lack of trying them on different statins to see if they're able to tolerate them. There's lack of the idea of ramping up or progressing the dosage of statin by starting them at a smaller dose and trying to titrate it slowly. And if they are really not tolerant to statins, then there's other options to try, which, that a lot of people give up. Either the patient's giving up or the physician's giving up, but somebody's giving up too soon, and we still have a lot of work to do. So the goal, LDL for primary prevention, again, LDL less than 100, and goal for elevated risk patients is less than 70. All right, and this is a basic risk calculator, atherosclerosis and cardiovascular disease calculator, this is called. And this is the basic calculator that you see on the right side of the screen here. And it includes gender, age, total cholesterol, HDL cholesterol, whether you're on treatment for hypertension, whether you're a smoker or not, what race you belong to, what's your systolic blood pressure, whether you're diabetic. But there's so many other risk enhancers, and I'm going to go into some of the details in just a little bit. But these are all the risk enhancers, and some of them are predominantly seen in women that are not included in the traditional risk calculator analysis. So maybe women are falling more into low-risk category, and that's why they're not being placed on adequate therapy, because they're losing out on the actual calculation by adding these risk enhancers that can. Then maybe they fall at an intermediate risk or a higher risk, and maybe they need to be treated more with medical therapy and aim for better goals, for better outcomes. All right, so that calculator, the ASCVD calculator, really helps us because this is an updated recommendation for primary prevention, which means we didn't have this patient never had a cardiovascular episode previously. And here, if it is based on whether the patient is definitely a risk, or no, they should never be on a statin, This chart helps us decide who needs a statin. So primary prevention for patients age 40 to 75 years of age, and if their ASCVD risk calculated is between 5 to less than 7.5, that's just like an intermediate risk, then we need to add those additional risk factors to see if they qualify towards the more higher risk factor needing medical therapy. And if it is for secondary prevention, which means they already had a coronary artery disease episode or an equivalent episode, or if they have hereditary hypercholesterolemia, like LDL was at any point greater than 190, then that's most likely familial. If they have diabetes, they're already on primary prevention with high risk or intermediate risk, then maybe they should be on a statin. But there is consideration for no statins, especially in pregnant female. They're definitely no, they should not be on a statin. And if they're on a statin and trying to conceive, the statin should be withdrawn. They should wait for 3 months before they get pregnant, or intending to get pregnant in the next 1 or 2 months. All right. Obesity. The impact of obesity on development of coronary artery disease appears to be greater in women than in men again. In the Framingham Heart Study, obesity increased the risk of coronary artery disease by 64%. So this is another risk factor that follows the hyperlipidemia risk factor, compared to 46% in men. And what can we do to overcome obesity? And what are things that describe, or what is obesity, right? So greater than 35 inches in general waist circumference for women, and 40 inches and greater in men, and a body mass index, which is calculated using your weight and height, that's less than 25 is appropriate. And how can you achieve or overcome obesity? You increase your activity, so you burn more calories. You eat fewer calories, focus on fruits, vegetables, whole grains, unprocessed food. You get enough sleep, aim for 7 to 9 hours each night, and work with your healthcare team, a nutritionalist and exercise specialist who can help create a nutrition plan and an activity plan to help lose weight. Physical inactivity affecting women differently than men again, because sedentary behaviors are higher among women than men. And this is a study that came out of NIH-sponsored study that came out of Cedars just, I want to say February 1st week or so. And they looked at about 4 million patients. Majority of the patients were women. I want to say about 65% of the population was women. And this study showed that compared to getting no exercise, women who engaged in moderate aerobic exercise for 2.5 hours each week had a 24% reduction associated risk for death, while men had a 15% reduction associated with death. So women had much more significant effect if they were to exercise regularly for 5 days or 7 days a week compared to the same amount of time that men would contribute. And actually, 3 years ago, ACC and AHA actually came up with the 150 minutes a week of walking or any kind of cardio activity, both for women and men, that would help decrease the cardiovascular risk and outcomes. And this study broke it down to specific numbers. So women, if they are able to put in 150 minutes of exercise minutes, not that, oh, I'm active during the day, I get 8,000 steps during the day, or I get like 10,000 steps a day, that's great. It's really great for women to be active and moving around. But this study specifically looked at leisure time activity. So you are actually taking that time to go exercise. It's your time, your me time to get better, because it's almost like a pill, right? Like 20%, 24% reduction is pretty significant. And I've been telling all my patients, I'm like, I'm prescribing hypertensive medications and statins and whatnot to help you get better. Doing exercise is like a pill. Like 30 minutes of exercise is like taking another pill, and you're adding to your risk reduction. So pretty profound study that came out just a few weeks ago. Smoking. My heart just broke looking at this. There's 1 in 7 high school students in the United States who used e-cigarettes in the past 30 days. That's pretty profound, right? I mean, for decades now, we know how bad smoking is and what all it causes, not just to cardiovascular risk, but so many other things. But for them to start so young, and I don't know what else we should do to make sure that stays out of their lives so young. But here, 1 in 10 female adults in the United States are currently smokers. That's pretty profound, right? I didn't think we would be so high. I thought this would be a number that I would see in Europe or Italy or France, where people are smoking so much all the time. But this is pretty significant, and a risk factor that can be altered. So smoking, in a recent meta-analysis, it was reported that in all age groups, with the exception of youngest women, had a significant 25% increased risk for coronary artery disease conferred by cigarette smoking compared with men. So nicotine makes your heart rate and blood pressure increase on a spike, not a chronic elevation, but in spikes. And those spikes are what are dangerous for cardiovascular health. Carbon monoxide is a harmful gas you inhale when you smoke, and tobacco robs your heart, brain, and arteries of oxygen, damages your blood vessels, and makes your blood sticky, a recipe for blood clots. It lowers your tolerance for physical activity and decreases the good cholesterol, the HDL cholesterol. And if you take oral contraceptives and you're a smoker, then it not only increases your blood pressure and it also increases your risk for stroke and heart attack. All right, that's all the traditional risk factors that we went over, and we see how they have a profound effect on the cardiovascular outcomes in women. Now let's look at some of the female-specific risk factors. And I think we can divide the life cycle of a woman into 3 parts. There's young women with menarche, PCOS, being on OCPs, having preterm menopause. There's pregnancy-related issues or adverse pregnancy outcomes based on gestational diabetes, hypertension, preeclampsia, and low birth weight. And then there's older women, post-menopause, women that are on hormone replacement therapy, and so on. So here I just wanted to focus on pregnancy, and Dr. Barry Merz, my mentor from Cedars, always says that pregnancy is like a nature stress test, right? You're going through this 9 months of stress on your heart while you're nurturing this fetus in your womb. And if you already carry some things with you that are going to be worse during that stress test, or make that are going to make you fail the stress test. So if you're already hypertensive, obese, having some dyslipidemia, have some insulin resistance, then during pregnancy you may develop gestational diabetes, preeclampsia, preterm birth, hypertrophy, or miscarriages and whatnot. And if you do have these adverse pregnancy outcomes, the more common adverse pregnancy outcomes that were studied, or the ones that contribute to cardiovascular risk factors, are gestational diabetes, preeclampsia, hypertension during pregnancy, early preterm birth for any cause, delivery before 37 weeks of pregnancy. Those are the more common conditions in pregnancy that were studied and that contribute towards cardiovascular risk factors. And if you do have any of those, then that puts you on a fast track to developing other risks for coronary artery disease as you age decades later, that you tend to have more coronary artery disease sooner than later compared to a female patient that did not have any adverse pregnancy outcomes. Okay, let's look at menopause. Now, this is a huge transition. We saw how the female population takes over, how the cardiovascular risk becomes more significant as women cross over from pre-menopause to menopause and after. So with menopause, of course, the estrogen component is what decreases, and there's significant increase in LDL, increase in ApoB protein, which is a component of the LDL. There's changes in the HDL quality, the good HDL that we had until menopause starts to decrease in numbers. There's visceral adipose tissue. There's increased fat mass and decrease in the lean mass. There's blood pressure that increases because of arterial stiffness that occurs. There's carotid intimal media thickness that increases, and metabolic syndrome risk increases. So multiple things that happen around menopause that place us at a higher risk than we were prior to that. And then there's more female-specific risk factors with autoimmune diseases like rheumatoid arthritis and SLE, which are more predominant in women compared to men. There's radiation and chemotherapy for breast cancer itself, so radiation that can have adverse cardiovascular outcomes decades later. Of course, now in the more recent era, the radiation being used is more focused, and there's less amount of cluttering around the focused area. So there's advances in radiation therapy itself that prevents more complications. But women that had radiation previously, like decades ago, could still develop some cardiovascular issues. And there's chemotherapy in breast cancer itself. There's specific drugs that you need to have a pre-drug evaluation of the heart. During the chemotherapy, you need to be evaluated. After stopping the chemotherapy, you need to evaluate it and then continue follow-up just to make sure you don't develop heart failure or an irregularity in your strain pattern for the heart and so on and so forth. And then depression and anxiety, again, is more common in women compared to men. So those were all the risk factors. That was a lot that were more common in women, and also the general risk factors. So the other very common question, or very common question that my patients ask me, or my colleagues, or my friends ask me is, oh, do women present differently for heart disease? Or they'll say, yeah, I know women present differently, but do we? I don't know. This study looked at women and men. This is a younger, like less than 55 years of age, that were hospitalized for acute MI at 103 hospitals in the United States. It's a specific study called the Virgo study. And here, in this study, they saw that 90% of women and men did present with chest pain, pressure, tightness, or discomfort. So chest pain was one of the presentations. So yes, we also present like men with chest pain, but we also present with 3 or more additional non-chest pain symptoms in comparison to men. So that's where the difference arises. That's where the dilution of our presentation, or the confusion that, oh, she's saying chest pain, but she's saying she's dizzy and has palpitations. Oh, maybe it's not cardiac, or maybe it's something else. Or, oh, it's chest pain, but yeah, I feel like I have some heartburn or indigestion, and I've been having it for a few weeks. Or, so that's where the female patient, and in this study, actually 64% women said that they didn't think they were having a heart attack or it was a heart-related complaint, versus 40% men thought that they were not having a heart complaint. But see how it confuses the mind of the female patient presenting to the hospital, and then it confuses the physician taking care of the female to recognize it on time as well. So understanding the difference in chest pain presentation is very essential, and we need to know what all are the common symptoms that we could present with, especially in women. So heartburn-like feeling, unusual tiredness, sudden dizziness, nausea or vomiting, cold sweats, and more common ones like chest pain. And chest pain can be pressure-like sensation or heaviness in the chest. It can be associated with shortness of breath. It can be associated with radiation, radiation to the arms and the back, like discomfort or tingling in the arms, back, neck, shoulder, and jaw. All right, so based on how a patient presents to the physician or to the ER, there's a lot of thought process. So that's why it's important to understand what our risk factor is when you're presenting with these symptoms, whether you're low risk, whether you're an intermediate risk, whether you're a high-risk patient. And when you present with chest pain, then what is the kind of testing that we need to refer a patient to, and how reliable is that test? And historically, all of the stress testing has been developed for coronary artery disease of the heart that's in the bigger blood vessels of the heart, the epicardial coronaries of the heart. So all of the testing was developed to look for major blockages, like bigger blockages in the heart. But we'll see that just going back here. So based on our risk profile, we go for stress testing, like with imaging, like PET or SPECT, or without imaging, like coronary CTs, or more definitive testing, like coronary angiogram. So coronary angiogram is like the gold standard, right? That's the test that will look at the blockage, will be able to fix the blockage as well. But here in this in this study, this is from the This is from the 2020 registry, CATH registry, and here they saw that amongst all the patients that underwent coronary angiogram for chest pain, about 60% of patients, women more than men, who undergo coronary angiography have no obstructive coronary artery disease, which means there's just very mild luminal irregularities, or they have non-obstructive coronary artery disease, which means they have less than 50% of blockage of the lumen of the coronaries. So that's pretty profound, right? Like more than half of the patients that are getting this very definitive test tend not to have any blockages in their blood vessels. Now, why is that? Let's take a look at this image here and understand the coronary artery anatomy itself. So this here is epicardial arteries, the bigger blood vessels that the coronary angiogram is looking at, seeing if there's a blockage and stenting. But if you look down here, the epicardial and the bigger blood vessels of the heart are only forming about 25% of the blood supply to the heart. But when you look at these smaller blood vessels, arterioles and capillaries, they make up to 75% of the blood supply to the heart. So significant amount of vessels that we can't see on an angiogram that could be involved, right? And this is a specimen of the heart without the muscle, and you can see the bigger blood vessels that you can see, and all this fuzz here that forms the 70-75% is the microvasculature of the heart. So coronary artery disease is not just disease in the bigger blood vessels that cause blockages, but it can be a disease of the smaller blood vessels of the heart that are not seen by the routine testing. And there's specific testing that's available for identifying this small vessel disease. And especially women tend to so among women that present to the hospital with chest pain, with EKG changes, with troponin elevation, and when they have coronary angiograms, up to 50% of us can present with no obstructive disease. So they go to the cath lab and they do the procedure and like, oh, there's no blockage. And they're like, oh, nothing, your heart's fine, you know, maybe we'll treat your blood pressure, or maybe you'll treat the cholesterol, or oh, maybe it wasn't the heart, I don't know, maybe you're having a UTI and that's why your, blood levels of troponin was elevated, or whatever. But now we have studies that looked at this 50% of the women that did not have blockage, and they looked at them with additional testing, like they had a cardiac MRI, or they had invasive ultrasound, like an ultrasound that goes on the wire, that goes into the blood vessels of the heart, to understand if there was anything wrong, anything that they have missed. And most common finding was that women have an erosion of plaque that happens, versus men have rupture of plaque that happens. So when it erodes, the plaque erodes and goes to a different branch or a different location. So when they're looking at the bigger blood vessels, they may miss out on that and not able to identify it and treat it appropriately. So that now we have more studies to look at this abnormality in the smaller blood vessels. And the smaller blood vessels don't necessarily present with obstructive disease. They present mostly with The smaller blood vessels present mostly with a physiological abnormality. The lining of the blood vessels is abnormal, so it's not opening up enough to allow for increased blood flow, or it's tightening to decrease the blood flow, or it's not changing anything, so the blood flow is going at a super high speed and causing destruction of the end muscle that's present. So there's specific testing to do that, and the gold standard for that is still the coronary angiogram. So you still go to the cath lab, you make sure your blood vessels are checked for obstructive disease, and when there's no obstructive disease, there's additional testing. You get adenosine or acetylcholine, other kinds of medications that you get during the procedure to understand if you have microvascular disease or not. And it's very important because the outcomes of microvascular disease are also profound. They have early onset of morbidity and mortality from obstructive disease or heart failure or recurrent hospitalization, poor quality of life, just bad things that can happen if it's not treated on time. And there are treatments available, and the treatments for the microvascular disease is also similar to obstructive disease, but it's more specified for what kind of pathway that's involved to change the trajectory. And then if none of the medications work, there's also like specified programs like EECP, a kind of physical therapy to help the smaller blood vessels to open, or different kinds of rehabilitation programs as well to help women that are struggling with microvascular angina. And all right, I'm going to stop. I think I said so many things. I hope you were able to grasp some of it. So I always like to finish with this. I tell women to be bold in taking care of your heart health. Check with your primary care provider, know your risks, and get heart checked. That's Dr. Nanette Wagner. I think she's 92 years old from Duke. All right, and that's it. Thank you. And I can take questions. Sorry, the question was, what's the name of the specific testing for the microvascular disease? What kind of test to ask for if we are suspecting microvascular disease? So whether you have microvascular disease or epicardial disease, if a patient is presenting with chest pain or symptoms concerning for possible involvement of the coronary arteries, there's always an algorithm we follow. So the first thing we do is it an acute symptom? Then you should be in the ER getting treated. If it's more stable and manageable as an outpatient, then we're starting to look at, are you a low-risk patient, intermediate risk patient, or a high-risk patient? Based on that, you will be referred to more non-invasive imaging kind of stress testing to see if you have obstructive disease, which is the first step to do in every case to rule out obstructive disease. And if you don't, and if you're still having chest pain, then you should have other testing to do. And the most specific testing for microvascular disease is called coronary functional testing, CFT. It is not offered at a lot of programs. There's only very few, very specialized centers offering it. So Cedars offers it, UC Irvine offers it, and now we're offering it at Long Beach Memorial. But apart from this invasive gold standard coronary functional testing, there's non-invasive testing with PET imaging. PET and cardiac MRI, stress cardiac MRI can identify microvascular disease as well, but they are not able to identify all the pathways of it. They just give us one pathway of the microvascular disease. You're welcome. Nice question. The question is, if you are a female patient, should you go to a female doctor who's a specialist in women's heart, or should you go to a male doctor? I think everybody should go to a female doctor. I think there was a survey that came out in 2018 where they did this whole survey in ERs, and the survey showed that female physicians had better outcomes for patients compared to their male physicians. So that was like a big deal. I was in my fellowship at Cedars at that time. So now the idea is that hopefully down the line in the future, every physician will be able to identify these conditions and refer these patients on time to get the testing done. But yes, if you are a female patient and if you are having chest pain, and it's always better to go to a female specialist that knows your condition or that can guide you appropriately. Or at least if you've had the basic testing done, like you were referred to a cardiologist, had some stress test done, and they said, oh, your stress test is fine, there's no obstructive disease, you're fine, don't worry about anything, and it's still bothering you, then you could ask them to refer you to a specialist that knows things about women's heart health, But microvascular disease and chest pain is not the only one. There's a lot of conditions in women that are not treated on time. Like a lot of valve conditions, women can have valve disease and they're referred to getting to a valve center or to a valve procedure much later. Like aortic stenosis is so much common in patients, both men and women, as you age. And older women that have aortic stenosis have been referred later and later to have the valve replacement procedure instead of identifying it ahead of time. So if you have a murmur, somebody should have done an echo on you. Not all murmurs are dangerous. Murmur is just the sound of blood flowing against the valve. But as you age, your valves get thicker and they can get tighter, so you need to be evaluated. So it's not just like microvascular disease or chest pain, but things like valve disease, even CABG. So female patients that go for open heart surgery, they tend to have poorer outcomes compared to their male counterparts because the number of bypass grafts they get is lesser, even if the lesions are the similar amount. So for example, if a female patient has 4 blockages and a male patient has 4 blockages, and you take like 20 women, 20 men, then of the 20 women, maybe 14 of them get all the 4 blockages fixed, and 20 of the men get all their 4 blockages fixed. And why is that? That's because women tend to have thinner, smaller, narrower blood vessels, so it makes it, and smaller heart, so it makes it harder. So there's a lot of research that's actually going into look to see, is it a technique issue or is it something else? Or maybe because female patients are older, in the 2 big studies that they looked at, the female patient that was getting a CABG procedure on open heart with bypass grafts was much older compared to the male patients that were referred. So are we referring them later and not ahead of time? So a lot of things like that, yeah.
Any clot busters, because as the vessels get smaller, it's harder to open them or stent them or whatever. Any chemicals like clot busters that will open up the smaller vessels?
No, not yet. And it's not always a clot in the distal vessels, right? Like I said, it's the lining, the endothelium, that's not functioning well to respond to the increased demand, so that there's not increased blood flow, not because of a clot, but because of an abnormality of the wall of the blood vessel. But talking about clots, so if women there are antiplatelets, right? Aspirin, Plavix, Brilinta, those are antiplatelets. And definitely women that have any kind of EKG changes, they've had chest pain, they went to the hospital and had a troponin elevation, but had a test that was negative for obstructive disease in the big blood vessels. Such women should also be on aspirin if there's no bleeding indication, because that antiplatelet will protect those smaller blood vessels too.
Up until what age do they be aspirin?
Up until what age? Most of the studies were, I think 80 was the cutoff for most studies, but we put them on our patients because we are living longer and we're seeing better results.
Another question.
I thought you had one small question.
You say aspirin, but some people have glaucoma as they get older. They can't take aspirin because of the glaucoma. Tylenol or any other type of situation?
So Tylenol is not an anti-inflammatory medication or antiplatelet activity. But aspirin or Plavix is another kind of antiplatelet medication that could be used. But again, not everybody needs to be on it. There's specific details about who can be on it. And the ASCVD risk that I showed you guys earlier, that helps us determine who needs to be on aspirin as well, or Plavix. Yeah. You're welcome.
Okay, so usually when you go, like for me,
Yeah, no, there's no preventative stuff or a specific test to do to rule it out. And I don't recommend, at least based on my knowledge so far, I don't screen asymptomatic women, no. Because if you're asymptomatic and your numbers are good and you're really like, your blood pressure is at goal, your cholesterol is at goal, you're doing all the exercise you need to do and whatnot, there's no indication for me to go looking for something. But if I had a patient today that came in and she runs 30 minutes a day, she's 52 years old, able to run for 30 minutes a day, no symptoms of chest pain, shortness of breath or anything. She went for a mammogram, and the mammogram showed calcifications in her left breast. That's what they said first. And then the doctor called her back and said, oh, it's not in your breast, it's in your heart that I could see the calcifications, and that's why she came to me. But she's fit as a fiddle, she's doing everything that she's supposed to, eats really well, very good lifestyle. But she has a significant family history. She had an uncle, a cousin, and her dad, all of them with heart attacks or coronary artery disease much younger in life. So when we say family history of heart conditions, that's a risk to us, is any male in the family with a heart attack or needing stents less than 55 years of age, and women less than 65 years of age. Those are they add to our risk for coronary artery disease. Beyond that, it's just, aging and whatnot would have caused it, but otherwise. So in her, she came in because she was like, her brother got a calcium score because her uncle just had a heart attack and he was doing really well. And so her brother got a calcium score and it was elevated and he started on a statin. She's like, oh, so I want a calcium score as well. So I told her I don't do calcium scores just like that, but I said just listening to her story, I would start her on a statin. And I looked at her LDLs, of course, were terrible over the years, and somehow the physicians had told her that it was fine when it was like 170 like 4 years ago, and then it was 150 and 143 was her last one. And I'm like, I don't need a test to start you on a statin. I would have started you on a statin, like, convinced you, got that LDL levels down. But I said, because it's been so significant over the years, I'm curious to know what your calcium score is. I'm definitely going to start you on a statin if you would allow me, because sometimes patients are hesitant to take any medication because they're so healthy and they're able to do everything. So in her, I did order a calcium score to see what it is and how high it's going to be, because over the years, there were so many opportunities for physicians who could have treated her for it, but they didn't. So I don't recommend testing for asymptomatic women. There's no screening that's recommended yet by ACC or AHA. I don't know if down the line if we'll come up with something, but for now the screenings are your annual screenings where you have to get your lipid checked once a year. You have to have your blood pressure numbers, your cholesterol, your A1C, and your electrolytes and kidney function. But yeah, I hope that answers your question. Because sometimes these very elaborate testing that people do, and they find an incidental finding that's really not significant and nobody can explain it, and it leads to unnecessary anxiety about, oh my God, what is this and what do I do with it now? And after 10 consultations and visits to the specialists and other specialists, then you're like, oh, it's nothing, okay, it's fine. So, and then AFib, you also mentioned about your husband and being really well and AFib. So it's hard to predict AFib. There are some conditions that could cause AFib, like people with sleep apnea, hypertension, obesity, alcohol dependence, diabetes that's poorly controlled. Those are some of the things that could lay the foundation for a patient to develop AFib. But it's really hard just on routine examination to screen for it, because your heart goes into this AFib or this arrhythmia like that, right? It just goes sometimes. And it's not like it stays there all the time. And only about 30% of the patients are symptomatic for it. A lot of them we don't know We don't know if you're an AFib or not. So, that's why when you go for your routine clinic examinations, you get an EKG or somebody's checking your pulse, listening to the heart, or things like that to catch it. But yeah, it's unfortunate that he had AFib, and unfortunately, AFib does increase your risk for stroke.
So I have another question. So you're talking about, you have those commercials, and then people have their little watches that's supposed to test the AFib.
Yeah.
Or the little cardiac thing.
Yeah.
Your mobile. Do you recommend those kind of things where you do it on your own?
Yeah, absolutely. So I see a fair amount of women that come to me with palpitations. Palpitations in itself is not a risk factor for heart condition, but a lot of women do come to me with palpitations. And some of them have it very regular. They say, oh, my heart is racing. It happens twice a week, or it happens every day, multiple times through the day. Then it's easy for me to put a little monitor on them for a week or two and capture these episodes and say, oh, okay, it happened this time, but you didn't feel it. You pressed the button this time, but nothing happened, to reassure them or to identify an arrhythmia that would have caused the episode. But there's some people that say, oh, so I feel my heart racing sometimes, but it happens rarely. It happened like a month ago, and then it didn't happen again, or it happened like 3 months ago, it was so significant, it didn't happen again. So in patients like that, I do recommend, like I say, oh, if you have an Apple Watch, you could do your EKG the next time, and you can actually send it to me. I can take a look at it. Or the Kardia device will capture it. If it's too short, then you want to get it, like Kardia device can help too. So definitely I do recommend it for patients that have palpitations, not for everybody. So plaque in itself, calcium doesn't have a role in the formation of the plaque itself. It's mostly to do with the abnormality in LDL levels and abnormal particles like apoprotein B, elevated CRP, or lipoprotein A, those things floating around that go and sit on the endothelium because of stiffened endothelium with aging and whatnot and other comorbidities. That causes a plaque. But calcium can go and deposit in the plaque and make it bigger or stabilize it too sometimes, but it does increase calcium scores. If you're somebody that has plaque and if you're taking aspirin calcium every day, then it can increase your calcium number, but it's a relative increase from what you already have. It's not because of the calcium. So if you do have osteoporosis and you need to be on a calcium, absolutely you need to be on a calcium. It's not going to make it worse for you. Yeah. I'm not sure about it. I'm not big on supplements. I believe in eating healthy food, like real food. So I encourage my patients to try and invest in better foods that are available. But as I practice it with everyday encounters, I learned that a lot of women do like taking supplements, and I'm starting to research into them. Like there was a patient that was taking beetroot powder in her smoothies because of blood pressure. So there's not really like randomized controlled trials or anything, but somebody said and people are seeing some difference and it's not harmful, then okay, fine. But
Is animal, I've also read that eating animal is not as healthy, in terms of cardiac things as plant protein.
I'm not a vegan, so I like my chicken and fish. But yeah, there are studies. Yes, there are studies to say being a vegetarian has better outcomes for your cardiac health. I don't know how big the studies are. There are a few cardiologists that are very big in promoting being vegan or being vegetarian to promote cardiac health. But I think having a good amount of good protein is also necessary for us through our aging process and through our hormonal process that we get along as well. So, yeah. Well, if they've done testing and you've had episodes of palpitations when you were wearing the rhythm monitor on and they could see the rhythm, what caused your palpitations, and they didn't think it was a bad rhythm, then there's nothing to worry. And also, absolutely. And I will say this, that palpitations in women, one of the most common causes for palpitation is stress.
That's what I've been
Yeah, and it's very unfortunate because when you start feeling, all of us have extra beats now and then coming from the top chamber or the bottom chamber of the heart, you know, and sometimes these extra beats form a rhythm and cause an abnormal rhythm. Some of them have names, some of them are just individual beats like PACs, PVCs, not really harmful. If they're less than 1% or less than 15%, they're not really harmful. But in patients that are stressed about it, they feel that one beat and they get anxious and they stress more about it. And then it goes on until there are patients that end up going to the ER because their heart rate is going so fast. They check their blood pressure, it's high, oh my God, and then their heart is faster. And then so it's like a vicious cycle. So stress is definitely a trigger for it. So you need to learn how to process your stress if you are a stressful person. If you're not, maybe your body is kind of telling you to, you know, take a step back and relax when you're getting these episodes, to kind of train your body to that. Exercise really helps with palpitations, like regular exercise, and even with high intensive HIIT training. Oh my God, I'm blanking out. High intensity interval training. That helps too. So you can create your own intensity level. So you go for a walk. So I always tell my women that when you go for a walk, don't go for a stroll. So go exercise. So you need to get short of breath. You need to break a sweat, you know, and then you stop, you take a break, you keep continuing. But not like just go for a stroll. I mean, you need to stress your heart. And that helps with palpitations too. You had a question too. Only if you're symptomatic. Yeah, only if you're symptomatic or if they feel like you're a high risk. I do see some patients that come in and then I find their cholesterol is high or their blood pressure is not appropriately controlled, and then I can start them on therapies to keep all those contributors under control. Yeah. Because of the inflammatory milieu it creates in the blood. There's so much inflammation happening with these autoimmune conditions that it causes the lipid particles to go and settle down on the endothelium more easily than not. Sure. Yeah. So I mean, if you need to be treated, you have to be treated. I'm not a rheumatologist, but you know, they have various ways of deciding when to put you on medical therapy that's more chronic versus only during an acute flare-up. So yeah, absolutely, because when you do have flare-ups, that's when your inflammatory condition is much severe at those times, and that's when I would think that the damage happens in those acute episodes that one has. So yeah, being on treatment. If you're not symptomatic and don't qualify for treatment, then there's no need to be on treatment for that. But yeah, I thought you were done with questions.
My grandmother had angina, you know, and they just said throw nitroglycerin underneath the tongue. What do you do for women who are experiencing angina? It's not a heart attack. It's any news thoughts on it since 30, 40 years ago?
So what do we do about angina in women? So, you know, you first rule out the contributors to angina. Angina doesn't just, it's not just chest pain exists. There's some either some disease in the coronaries, the epicardial coronary arteries have disease in them, or there's microvascular dysfunction. If they don't have any epicardial obstruction, no need for a stent. If they don't have any microvascular disease, they don't need any medication or treatment for that. Then some women tend to have increased nociception, we call it. They have an increased sensation of things that happen with their heart that can present as angina. And when we've ruled out other contributors to chest pain, then we could treat them with tricyclic antidepressants like amitriptyline, which helps in pathway alignment so that they don't sense it as significantly. But a treatment for angina, if patients have had stents or microvascular disease and ongoing chest pain and acute episodes, nitroglycerin is the treatment of choice. Whether it's a short-acting under-the-tongue one or long-acting ones like Imdur or isosorbide dinitrate. Those are the treatments. They haven't come up with anything new yet. Yeah. Yes. Okay. I think so. Each of us will have different metabolic rates, right? Like each one's body metabolism is different. For example, like I work out for 30 minutes for 2 weeks and lose 2 pounds maybe. My husband works out for 60 minutes for 2 weeks and gains a pound. And we both could be eating the same thing. It's just, you know, our metabolisms are different. His resting heart rate is 60 or 55 to 60, and my resting heart rate is like 70, 75 is my resting heart rate. So we're all different when it comes to that. But if your baseline heart rate is greater than 100 to begin with, or you start exercising and within 30 seconds your heart rate is picking up really fast, or it goes up and stays there for a long time, then those are things that we can look into to see if there are contributors to that. But it by in itself, I don't think is a risk factor for you. Yeah. And maybe you need to hydrate more as well. Oh, I don't know about a supplement instead of aspirin. The only alternative we use in a clinical setting for a patient that needs to be on an aspirin is probably Plavix or Brilinta. There's definitely, for patients that need a stent, if they have coronary artery disease and they need to be on an aspirin, there are centers that do a desensitization testing. Or if they have gastro side effects, one of the most common side effects, then you can use a gastric-coated aspirin, which is less potent than the non-coated one, but it still has its antiplatelet effect. But as far as my knowledge goes, we do not prescribe a supplement for aspirin. Yeah. Maybe. I'm sure. Yeah. There's a lot of holistic people out there that do stuff that I'm not sure about it. I don't practice it. Yeah.
And I know the calcium are in menopause.
Come see me. That person should definitely be more aggressively treated and followed, and a lot of things to go with, because too many things that contribute to an early onset of coronary artery disease, as well as too much of stress from the fact that she would have experienced all of that. So that person would need special care. Yeah.
Is that lit? You have the American College of Cardiology and ASCCD.
Yeah.
So we could go online.
Oh, yeah, on Google.
And it has all the risk factors. It has all that stuff.
So when you go check it online, you'll have that ASCVD, the original one with just the main things that I mentioned, with the blood pressure and race and HDL, cholesterol levels, diabetes, and what was the other one? Weight, I think, is in there. But it doesn't have the additional risk factors. The new ones should be available, so maybe if you search for ASCVD with additional risk factors, it should pull it up.
And there would be the risk factors she's talking
Yeah, yes.
about. I've never heard that.
But it doesn't, so these additional risk factors that I mentioned to you guys about, the risk enhancers, those are called, they don't get inputted into this algorithm. It's for us to understand that when a patient comes with these risk enhancers, then the risk calculated by the traditional risk factor changes, because we need to take into consideration these risk enhancers. So it's just a knowledge of knowing that this particular patient has these risk enhancers and how that would change her from a low risk to an intermediate, or an intermediate to a high risk. Yes.
Are you taking new patients, and where do you
I am taking new patients, and our office is at Douglas Park. It's by the Long Beach Airport. Thank you.
These have all been excellent questions, so thank you all for your participation tonight, and thank you, Dr. Sapogu, for such a wonderful and informative presentation. Thank you all for coming, and we hope to see you at our next Connect to Healthy Living event. If you're not registered already for next week, March 12th, we have another event coming up. So thank you again.